which is used for the diseases of spinal cord or all the pathologies which are involved for spinal cord. And it can be traumatic, that is termed as spinal cord injury, can be inflammatory, that is known as myelitis, and can be vascular, that is termed as vascular myelopathy. The signs and symptoms of myelopathy depends on the level and extent of the involvement of the spinal cord. For example, if there is involvement of cervical or dorsal or thoracic or lower dorsal spinal cord, the signs and symptoms vary according to the level. In the same way, the extent of the involvement of the spinal cord, whether it is involving the anterior part of the spinal cord, posterior part, or lateral component of the spinal cord, that will be assessed, that will be shown in the signs and symptoms. You know, when there is involvement of the spinal cord, there are upper motor neuron signs, and in upper motor neuron signs there is weakness, but this weakness is spastic, which causes clumsiness and increased tone, and associated with hyperreflexia with extensor response in the plantars. It may or may not be involved with sensory deficits along with sphincter dysfunctions. We can classify compressive myelopathy according to various causes. It can be congenital, acquired, neoplastic, infectious, or vascular. The most common congenital anomalies that can cause compressive myelopathy are Arnold-Chiari malformation and syringomyelia. In fact, syringomyelia is associated with Chiari malformation. In acquired causes, which can be described as degenerative causes, the most common cause is herniated intervertebral disc, followed by spinal stenosis, ossification of posterior longitudinal ligament, commonly known as OPLL, and thickened or calcified or ossified ligamentum flavum. The tumors of the spinal cord or spinal axis can be classified as extradural, intradural extramedullary, or intramedullary tumors. In extradural category, metastases are the most common tumors, followed by primary bone tumors, while in intradural extramedullary category, meningioma and neurofibroma are the most common cause. While intramedullary tumors, ependymoma, astrocytoma, hemangioblastoma, dermoid, epidermoid, lipoma, these are the common types of tumors that belong to this category. In infectious cause, the most common cause of spinal infection in our society is TB osteomyelitis, that is commonly known as Pott's disease. Other examples are epidural abscesses and arachnoiditis. In vascular causes, there are epidural hematoma, hematomylia, that is the hemorrhage within the cord. And basically, these two abnormalities are caused by ruptured arteriovenous malformation of the cord. So these are different classifications, different causes on the basis of their appearance. This picture describes various sites of compressive myelopathy. If it is outside the dura involving the bony component, it will be termed as extradural extramedullary lesions. And the most common cause of these lesions are metastases and primary bone tumors. The second category is intradural extramedullary, that is within the dura but outside the cord. And this is the category in which meningioma and neurofibroma are most common. And then comes intramedullary category, that is the lesion within the cord substance. Now we will discuss every anomaly separately. So first of all, Carey malformation. Carey malformation or Arnold Carey malformation is basically herniation of the cerebellar tonsils below the level of the foramen magnum within the spinal canal. Scientifically, if it is more than 5 millimeter below the foramen magnum, then it will be termed as type 1 Carey malformation. It is usually found in adults and is associated with syringomyelia. You can see in this picture, this MRI T1 weighted sagittal image, that there is herniation of cerebellar tonsils below the foramen magnum into the cervical canal, that is causing crowding of the contents of the cervico-medullary junction or craniovertebral junction. And it is the most common cause of formation of cavity within the spinal cord, which is called syrinx or syringomyelia. The second type of Carey malformation is in which vermis, pons, medulla, and part of the fourth ventricle herniate below the foramen magnum, and it is usually found in neonates or early ages. And this is the category which is associated with myelomeningocele and hydrocephalus. The treatment of Carey malformation depends upon the symptomatology or neurological condition of the patient. If the patient is asymptomatic, that is, this condition was found incidentally, then the patient should be followed. But if the patient is having symptoms like patient is having hydrocephalus or he or she has an obvious myelomeningocele, so these patients may need surgical intervention. For example, if the patient is having weak hydrocephalus, he or she may have VP shunt inserted or posterior fossa decompression. That is the main treatment modality of Chiari malformation. Syringomyelia is basically a cavitation of the parenchyma of the spinal cord. And the difference of syrinx with central canal is usually found in the center of the spinal cord, while syrinx is usually eccentric in the location within the cord parenchyma. Syringomyelia has a specific clinical condition, clinical symptomatology, that is central cord syndrome, in which there is suspended dissociated sensory loss. Suspended dissociated sensory loss. That means the sensory modalities are suspended at the level of the syrinx, and some modalities are involved while others are not involved. That is called dissociated sensory loss. Mainly pain and temperature is involved due to the location of the tracts, while other modalities remain uninvolved. And this syringomyelia is also associated with dysesthetic pain, lower motor neuron type of weakness in upper limbs, which are usually weakness and wasting of hand muscles, and upper motor neuron signs in lower limbs. Treatment usually is on the basis of the cause. If the syrinx is due to Chiari malformation, it is treated by posterior fossa decompression as in Chiari malformation. If there is isolated syringomyelia, then it can be treated by shunting procedure, syringo subarachnoid shunt, or syringostomy. Syringostomy is basically just opening of the syringomyelia or syrinx cavity within the subarachnoid space. Now, the most common degenerative cause causing compressive myelopathy is spondylosis, mainly cervical spondylosis. Spondylosis is basically a term which is the combination of degenerative changes in which there is degeneration of the disc, spinal stenosis, degenerative facet joints disease, formation of osteophytes, or combination of all. So these degenerative changes comprises spondylosis, which is the most common cause of compressive myelopathy in our society, especially in elderly individuals. In this picture, you can see the levels or stages of only one part of the spondylosis, that is disc degeneration. To understand disc degeneration, we have to know the anatomy of disc. The intervertebral disc is composed of two main components. In this picture, we can see a pink part, peripheral part, which is basically the annulus fibrosus, and the central gray part, which is called nucleus pulposus. You can see there is tearing of the fibers of the annulus fibrosus. That is the first stage of disc degeneration, in which there is desiccation and dehydration. This process proceeds further the prolapse of nucleus into the weakened part of annulus fibrosus that may lead to further herniation or extrusion of nucleus outside the disc. In some instances, these disc fragments can go outside the annulus and can impact within the passages of the spinal nerves or nerve roots. These are the theoretical or stages of the disc degeneration. So basically, disc degeneration is started with disc dehydration or desiccation, followed by prolapse, herniation, and may lead to extrusion or sequestration of nucleus pulposus outside the annulus fibrosus. The other components are osteophytes formation. This is basically a sagittal reconstructed CT scan of the cervical spine in which you can see a posterior osteophyte in the lower end plate of C5 and upper end plate of C6 on the posterior part, that is the part which is associated with the spinal canal. So you can understand these two bony osteophytes can compress the neurological components within the canal. It is usually associated with decreased in disc height as the time passes and associated with narrowing of the spinal canal. This is sagittal image of T2 weighted MRI cervical spine showing the same patient with disc herniation at the level of 5 6 and 6 7, 5 6 and 6 7. You can see the flow of CSF in front and behind of the spinal cord at the level of C2 and at the level of C7. You can easily appreciate a thick film of CSF in the form of white color in front and behind of the spinal cord. But at the involved level, that is C5, C6, there is no CSF space. In fact, a cord is squeezed or compressed by these disc herniations at the level of C5 6 and C6 7. You know, the marking of cervical vertebrae starts from the second cervical vertebra, which is thumb like. So this is second vertebra, third, fourth, fifth, and sixth. C5 6. This disc will be termed as C5 6 intervertebral disc, and this disc will be termed as C6 C7 intervertebral disc. And this is D1 because cervical spine has 7 vertebrae. So this is dorsal, first dorsal vertebra or first thoracic vertebra. You can also appreciate there is slight thickening of ligamentum flava. Ligamentum flava. Sometimes we can have a thickening of posterior longitudinal ligament. This is basically the posterior longitudinal ligament which runs from clivus through spinal canal behind the all vertebrae within the canal. So this is called posterior longitudinal ligament. If this ligament is thickened or calcified, this may lead to narrowing of the canal or compression of the cord. The same applies with ligamentum flavum. LF stands for ligamentum flavum. PLL stands for posterior longitudinal ligament. Now comes the clinical aspects of the spondylosis. We all know the well-known description of sign and symptom of cervical spondylosis is upper motor neuron signs in lower limbs and lower motor neuron signs in upper limbs. And it is basically due to compression of the cord, usually in the cervical region. We know the level of the cord which is compressed can present lower motor neuron signs. So usually upper limbs have lower motor neuron signs, that is wasting, weakness, decreased reflexes, while the upper motor neuron signs, that is the areas which are involved below the level of the compression, are usually presented by upper motor neuron signs. That is why in lower limbs we have upper motor neuron signs, extensor plantars, brisk reflexes, hyperreflexia, and spasticity. So cervical spondylosis is the most common cause of progressive myelopathy, especially in elderly individuals, usually found in patients or individuals of 40 or more years of age, more frequent in males than females. C56 is the most common site involved because this is the most mobile part of the cervical spine. And as the mobility increases, the chances of degeneration or stress injuries increases. That is why C56 is the most common level which is involved in cervical spondylosis. Management. Whenever the term management comes, we have to describe it in two or three main components. First of all, medical or conservative management. In every disease, we usually first starts with medical or conservative management, and if this management fails, then we usually proceed further to surgical intervention. So in this condition, conservative management comprises of usage of analgesics, usually non-steroidal anti-inflammatory drugs and NSAIDs, application or wearing of cervical collar, physical therapy, and lifestyle modification. We all know that due to increased usage of electronic gadgets like mobile phones, tablets, laptops, computers, LEDs, TVs, these all gadgets, or in fact excessive usage of these gadgets, may lead to change in the actual or natural cervical curvatures that will lead to the increased stresses in the components, mostly in the mobile components of the cervical spine, and that may ultimately lead to cervical spondylosis. So if a person is a banker or an IT professional or a young male which is not on job and used to use his laptop, mobile, or tablet, you have to counsel these individuals to take care of their cervical posture or posture of their neck. They must not use these gadgets without proper cervical posture. And if these conservative management or conservative measures fails, then we have to proceed for surgery, which is usually decompressive. That is, we have to remove the component which is compressing the cord or neurological structures. The indications for surgery are moderate to severe myelopathy and progressive neurological deficits. That is, we have been providing conservative management to the patient, but the patient is having progressive neurological deficits. This is the indication for surgery. Or if the patient is having intractable pain which is not controlled by any medical treatment. So these are the main three surgical indications. Now comes the approaches, surgical approaches for cervical spondylosis. There are usually two types of approaches: anterior approaches, in which there is most common approach is anterior cervical decompression or anterior cervical discectomy with or without fusion, which is usually known as ACDF, anterior cervical discectomy or decompression and fusion. It may or may not be associated with fixation or placing an implant, which is fixed usually, in which there is a plate which is fixed with the help of screws. The other approach is posterior approach, which have a lot of variety, like laminectomy, in which we have to remove the lamina. This laminectomy can be done alone, or if the levels of laminectomy are more, it can be uh, associated, or it can be added with lateral mass, screw fixation, and fusion. In some individuals, laminoplasty is the procedure of choice, and in some, we have to have multiple level foraminotomies only. So the approach in is basically determined by the disease, whether the compression is more from the anterior aspect or from the posterior aspect. Sometimes we have to combine both approaches simultaneously or in stages. For example, if the patient is having anterior compression as well as posterior compression, so sometimes in selected individuals we have to decompress anteriorly as well as posteriorly when the same sitting in the single surgical session or in phases or stages. These are this is basically X-ray cervical spine lateral view, and you can appreciate there is an implant in the anterior part of 5 and 6, in which you can see a plate in front of cervical fifth and sixth vertebra, which is fixed to these vertebra with screws. There are four screws, two in the fifth vertebra, two in the sixth vertebra, and if you see, you can identify a bony graft within these two intervertebral space. So during decompression, whole of the disc space is emptied and a tricortical graft is taken, most commonly from iliac crest, and placed between these two vertebrae, so that the strength is increased by permanent fusion of these two vertebrae, C5 and C6. This is another picture in which you can see the same X-ray cervical spine lateral view, but in this time, this is basically posterior decompression, in which there is decompression of the occiput, upper cervical vertebrae, along with fixation of lateral mass screws in the cervical spine and screws within the occiput. This fixation is termed as occipito-cervical fixation because we have involved two parts of the skeleton, occiput and cervical spine. So this is termed as occipito-cervical fixation. Usually in this fixation, graft is placed as well to strengthen the permanent fusion. So this is anterior approach and this is posterior approach. In some instances, selected patients, we have to do both surgeries: anterior decompression, posterior decompression, anterior fixation fusion, posterior fixation fusion. Now comes the tumors. I've shown initially that spinal tumors can be classified on the basis of their location. If the tumors are located outside the dura, which is the most common site, these are termed as extradural tumors. And if they are inside the dura, they are called intradural tumors. And these tumors can further be divided into extramedullary or intramedullary tumors. And as we have discussed, extradural tumors, most common tumors are metastases from various sites, primary bone tumors, or vertebral hemangiomas. Intradural tumors are meningioma, neurofibroma, and intramedullary tumors, ependymoma, astrocytoma, hemangioblastoma, dermoid, epidermoid, lipoma. We have already discussed in extradural category, primary tumors are rare. Usually, the extradural tumors are metastases. And in this category, dorsal or thoracic spine is the most common site, specifically in a known patient of a malignancy with chronic back pain. The common sites are lung, the common primary sites are lung, breast, gastrointestinal tract, prostate, melanoma, and lymphoma, or multiple myeloma. So the treatment depends on the overall condition of the patient as well as the stage of the primary disease and the involvement of the neurological component as well as the pain which is associated with malignant disease. If the patient is medically fit, or that is, he or she can undergo a surgical decompression, and he or she has intractable pain due to metastasis or have a gross progressive neurological deficits, so these are basically the indications of decompression in such malignant conditions. So this is MRI dorsal spine T1 weighted image showing a hypointense vertebra at the level of T4, sorry, 5, T5, T8, 9, 10, 11, and 12. You can appreciate that the vertebral involvement is associated with canal compromise and cord compression at both levels. The axial views, you can appreciate the extent of the disease within the canal and lateral components. So the goal of treatment in such patients is to decompress the neurological components, to stabilize the spine, and early mobilization. And that can be done by surgery alone or in combination with post operative radiotherapy, or in some instances with radiotherapy alone. Intradural extramedullary lesions. The most common tumors are meningioma and neurofibroma. The spinal meningioma are 4 times more common in females than male. Usually, the site is dorsal spine, followed by cervical and lumbar spine, and complete surgical excision is the treatment of choice. Neurofibroma is basically from Schwann cells. It usually has a course through the neural foramen. That is why it presents a dumbbell shaped tumor. You can appreciate in this axial view there is a tumor which is within the canal compressing the cord and going outside the canal through the neural foramen, making a shape of a dumbbell. This is MRI T1 weighted image sagittal view with contrast enhancement. You can appreciate a homogeneously enhancing lesion with broad base and dural tail sign. So this is a meningioma and this is a neurofibroma. These are sagittal images and this is axial images. The surgical treatment of both neurofibroma and meningioma are complete surgical excision. And in neurofibroma, we have to sacrifice the nerve which is involved in the tumor formation. Intramedullary lesions are very rare, commonly found in cervical region. The most common are ependymoma, astrocytoma, followed by hemangioblastoma. The benign category is dermoid and epidermoid, which can be found along the course of the spinal cord or the conus medullaris. And in these type of tumors, we cannot excise all of these tumors completely. So the goal of surgery is microsurgical decompression or debulking, and it can be combined with radiotherapy if the lesion tends to be a malignant one. Infections. The most common cause of infection in our society is TB osteomyelitis, but we can have isolated epidural abscesses, which has a triad of fever, spinal pain with progressive limb weakness. And these epidural abscesses, two-thirds are hematogenous, while one-third have a local spread. The main culprit is Staph aureus, followed by gram-negative bacilli. The mainstay of identification or diagnosis is the history and examination, which can be uh, followed by blood workup like ESR, and CRP, the diagnosis is confirmed by radiological imaging like MRI with contrast images, and sometimes we have to send bacterial cultures. The treatment is decompressive laminectomy plus drainage of the abscess with prolonged intravenous antibiotics. Now comes the most common infection, which is TB spine or Pott's disease. The most common site is dorsal spine or dorso-lumbar junction, and the patient usually have more dysfunction of the motor activity than the sensory modality. This flow chart shows the pathophysiology of the TB osteomyelitis. Extraspinal source of the infection, that is blood spread. It goes through the bloodstream, and the bacteria resides in the uh, end plates of the vertebral body. It spreads adjacently to the adjacent disc spaces. This will lead to bone destruction and further adjacent bone involvement, and this bone destruction causes kyphotic deformity if it is in dorsal spine, and abscess or granulation tissue formation. These abscesses in the dorsal spine or dorsolumbar junction can spread through the facial planes to far more areas like sauce abscess, in which the abscess is in the inguinal region, but the disease is at the dorsolumbar junction. And all these abscesses, granulation tissue, or direct bony destruction can lead to spinal cord compression and neurological deficits. So, the first feature of these patients is backache, which is usually spreads over months. It may or may not be associated with low grade fever and weight loss. Usually, the pain is spinal, but sometimes it can be radicular, that is, it spreads in the dermal distribution of the nerve roots. If the patient is not diagnosed early, he or she may have neurological abnormalities as well. Therefore, more 50% of the patients have neurological deficits, which is due to the compression of the spinal cord and depends on the site and degree of cord compression. If the patient is having cervical osteomyelitis, he or she may have quadriparesis, or the patient is having compression of the dorsal cord, he may have paraparesis. The diagnosis, we have to have a good history examination and blood workup and radiological examination like X-ray, CT, MRI. In our society, teenage girls or teenage females have most of the TB osteomyelitis. So, whenever a young lady comes to the clinic with chronic low backache, along with weight loss, low grade fever, you must think about Koch disease or TB spine. This is X-ray of the dorsal spine, dorsal lumbar junction. You can see the one of the vertebrae is completely destroyed. This is another vertebra, this is another vertebra, and this is another. So there are three vertebrae, one, two, three, and the space these three vertebrae occupies is adjacent, is equal to the space occupied by two vertebrae. So the destruction of the vertebrae has reduced the vertebral heights and causes kyphotic deformity. This is AP view of a patient with spinal tuberculosis with paravertebral abscess. You can see this is the vertebra which is compressed, as we can see the decreased height of this vertebra along with paravertebral abscess. You can see the soft tissue. This is not hard. This is paravertebral abscess, which is showing a soft tissue on both sides of the vertebra in AP projection. These two images are MRI, dorsal spine, T1 weighted images with contrast enhancement, and we can see the involvement of one complete vertebra along with a granulation causing compression of the spinal cord. We can appreciate a signal change within the spinal cord, a very subtle brightness within the spinal cord. Treatment is anti-tuberculosis treatment, immobilization, that is bed rest, analgesics to reduce the pain, and if these conservative or medical measures fails, then patient needs surgical decompression. And the indications are if we need early mobilization or the patient's neurological recovery is delayed, or he or she having progressive neurological deficits, or the patient is having a large paravertebral abscess, or the disease is causing instability of the spine, or the patient is having intractable pain. So these are the indications of surgery. There is one more indication: if the patient is having deformity. If the patient is having deformity due to destruction of the spine, it is another indication to have a surgery. In vascular category is very rare, in which there may be a epidural hematoma. It is usually found in those patients who are on anticoagulation therapy for some reason. It can be a trauma or bleeding disorder or a tumor. And epidural hematoma causes sudden acute symptoms. So whenever a patient comes with sudden, like a snap of a finger, comes with the symptoms which are very sudden, we have to keep in mind a vascular phenomena. Hematomylia is basically the hemorrhage within the cord substance. It causes acute, painful myelopathy. If the cause of these conditions is AVM, it can be managed by surgical intervention. Thank you. So this was all about compressive myelopathy. If you people wants to ask any question, you can chat. I am going through all the slides again very slowly. कैसे कौन से लेगा क्वेश्चन वो पूछना चाहिए आ रहे क्वेश्चन so anyone want to ask anything you can chat in the box.